Hi, everybody. Thanks so much for joining. We'll just give it another minute for everyone to come in from the waiting room.
Hello, good afternoon.
Good afternoon, everybody. Well, thank you so much for joining us, everyone, today for this Hepatitis C Elimination Community of Practice webinar. We are so thrilled to have you all here today to hear about some really incredible work happening in Hep C elimination with a particular focus on street medicine. So before we jump in to the webinar, I wanted to provide just a little bit of background for those who are perhaps a bit newer to INSU. So INSU stands for the International Network on Health and Hepatitis and Substance Users. We are a not-for-profit member-based organization, and we're dedicated to the health and well-being of people who use drugs. We have sort of three key pillars of work. We have a knowledge exchange arm. Most notably under this sits our annual conference, this year to be held in Cape Town in October. We run education and training programs globally, focused on hepatitis C and harm reduction, and we do work in policy and advocacy as well. We are governed by our members and our board, and we carry out our programs are carried out by our secretariat, who is based in Sydney in Australia, which is where I'm currently joining from. A few acknowledgements before we kick off. This program of work has been developed by INSU, but in really close collaboration with our incredible partners, the National Alliance of State and Territorial AIDS Directors and the Coalition for Global Hepatitis Elimination, who we have worked with on this program since 2022. A big thank you to our sponsors, AbbVie, Gilead, and Roche. We're really grateful for their support in enabling us to put on both our in-person and our virtual events, and our sponsorship policy is listed up there on the screen for you to take a look at. A bit of background as to how this community of practice was actually formed. A couple of years ago, INSU, in collaboration with our local partners, we developed a Hep C intervention toolkit. And this digital toolkit profiled a range of different interventions which had been demonstrated to enhance the Hep C care cascade. So such as interventions like dried blood spot testing, point of care RNA testing, care navigation, peer support, etc. And you can actually access all those how-to guides for free on our website. They are accompanied by a range of best practice models of care infographics and different films showcasing innovative models of Hep C care from around the globe. The how-to guides provide really practical sort of step-by-step information as to how to actually set up these interventions in your service setting and how to scale up their use. It looks at different best practice examples, different challenges that you might encounter when attempting to implement and how to overcome these, and it provides a really solid evidence base. But the toolkit was always intended for a global audience. As we know, the challenges for implementation are not only going to be different from country to country, but city to city, and in many cases, service to service. So we wanted to provide people with that opportunity to come together in person to discuss barriers and enablers to implementation. So subsequently, in a collaboration with an incredible committee, we developed a one-day in-person training program to support people to develop or to enhance their own models of Hep C care, as well as to build and establish connections with other providers. I want to take a second here to acknowledge the amazing committee who worked with us to develop this program and thank them for their time and contributions. We began piloting this program in 2022 in the UK and Canada, followed by the US in 2023 and in Portugal in 2024, and we'll be introducing it in Australia this year. Since the inception of the program, we've delivered 16 symposia to over 700 attendees, as per the breakdown that's listed up there on the screen. And the audience is really multidisciplinary, a mix of physicians, nurses, pharmacists, peer workers, programmers, and policymakers. And we've delivered our first community of practice webinar for participants of these symposia last year in September. You can see there up on the screen our upcoming symposia to be delivered in 2025 across the US. If you're interested in either coming along or if you're interested in hosting a symposia, if you think it's something that we might be beneficial to bring to your state, please do feel free to get in touch with me. We'd love to chat further. The community of practice was intended as a way for participants of the symposia to reconvene and sort of continue to discuss challenges they were having with their hepatitis C intervention implementation, focused around different topics. We've also expanded the community of practice to open it up to people who were not able to join us for our in-person symposia. And so just want to thank you again for your time today and coming along to hear about street medicine. I am thrilled to introduce some incredible presenters today who have come along to share their models of street medicine with us today and to have some Q&A. I'm thrilled to introduce Brett Feldman, the Director of USC Street Medicine, Associate Professor of Family Medicine at the University of Southern California. Matt Beer, the Program Director for Addiction Medicine Fellowship at Clinica Sierra Vista in Bakersfield, California, and Benjamin Eckhart, Assistant Professor of the Division of Infectious Diseases and Immunology at NYU School of Medicine. Thank you all to our presenters for joining us today. As you can see there up on the screen, we will be hearing from each of our presenters who are going to cover different models of rural and urban street-based medicine and look at different key features of the model, challenges, successes they've faced, and any lessons learned in implementation. And we'll have some time at the end for Q&A. I encourage you to put your questions in the chat throughout the presentations. And at the end of the presentations, we'll also have some time for you to take yourselves off mute and pose your questions directly to the presenters themselves if you wish to do so. So without further ado, I'm going to give control to Brett Feldman, who is going to walk us through his model of care. Thanks so much, Brett.
All right. Thank you, Liv. And thank you, everybody, for coming. My name is Brett. I'm the director for street medicine at USC, University of Southern California. I'm also the vice chair of the International Street Medicine Institute, which is our international organization. My role in the institute is to provide technical assistance to our members. We have about 200 members around the world. I've been doing street medicine since 2007. And since I'm the first one, I'm also going to talk to you about what is street medicine. And so street medicine in general just recognizes that people experiencing especially unsheltered homelessness can't access healthcare the way that somebody who is housed does. And in order to care for them properly, we have to address all the different forms of poverty that afflict them. So of course, there's the material poverty for want of a home or want of food. And we know in Los Angeles, where I practice, about 30% get 3 or less meals a week. There's the poverty of health, the physical comorbidities, substance use disorders, and psychiatric disorders that, if not treated now while they're still on the street, will prevent them from ever walking over that threshold into housing or keeping their housing. But as horrible as those things are, the worst poverty that we see is the spiritual poverty of feeling unwanted or unloved. Poverty only deepened every time they're pushed around a city that they feel is their home, but with no place to put their physical body. And so street medicine is our answer to those those poverties. Oh, that is a sensitive button. Okay. There you go. So this is just some places where street medicine is in the world. These are some of the members of the Institute. But street medicine is defined by health and social services delivered specifically to people experiencing unsheltered homelessness directly in their lived environment. So this is both the historical and global definition of street medicine. In the United States, for the first time, this was defined in some sort of statute nationally, where they created a new place of service code, which is how we get reimbursed for care for the street. So it was very similar location on the street or found environment, not described by other place of service codes. So for example, mobile medicine, distinguishing street medicine from mobile medicine, where treatment is delivered specifically to unsheltered homeless individuals. And so one of the things I wanted to make sure that we can all imagine why it's important to distinguish street medicine from mobile medicine. And there is a philosophical difference and a practical difference. So philosophically, we want to be able to suspend our reality and meet the people in their reality where they feel most comfortable, to intentionally flip that power dynamic in their favor, where even if we drive in proximity to them and we park, we take them out of their environment into our environment. We flip that power dynamic back in our favor where we don't want it. Practically speaking, this is a map of Lincoln Heights, which is in Los Angeles. And the red cross on the bottom is the big county hospital that is designed to care for people experiencing homelessness. To the upper right, where you see that van, is Lincoln Park. That's where a van would park. And I'm so glad that they park there because they can add like laundry services and clothing services, and there are people experiencing homelessness there. But the problem street medicine is trying to solve for is that the largest encampment in the area is where that heart is. It's over 2 miles from the van and about a mile and a half from the hospital. And so if you can't leave your encampment because everything you own will be stolen to go to the hospital, you also can't leave to go to the van. And so in response, we go to the people in this assertive way. This is how it looks on our team. We have a pickup truck and backpacks. We go out on foot. The core of the team is somebody who can prescribe, so a doctor, physician assistant, or nurse practitioner, a nurse, and community health workers who are people with lived experience in homelessness. You need somebody to prescribe, otherwise you're relying on getting them back to the clinic in order to get any medication. We do a very high level of wound care. This is one of our PAs, Corinne, who was taking care of a gentleman who suffered from a substance use disorder. And he had been in the hospital and had a nasty abscess, ended up getting a wound debridement with 7 needles that had broken off into his uh, side. And they recommended a wound vac, which would require him to go to a nursing home, which he didn't want. So he went back out onto the street, and between his effort keeping it clean and our effort trying to clean it, it eventually healed. Dr. Olson doing ultrasound on the back of a truck bed. Um, but the scope of practice of street medicine is actually very high. We did a landscape analysis for street medicine with over 70% practicing what would be considered full scope primary care and preventative medicine and care for behavioral health disease. 80% bring medications and dispense them on the street. Over 50% draw labs on the street, take blood, plus much, much more. And it's in this context that we intermingle care for hepatitis C. So this is not a separate team, but is done in concert with the rest of the team. And the reason why it has to do that we have to do it this way is because even though a lot of folks are insured, people don't have access to the brick and mortar clinic, access to their primary care. So in LA, we published a study, 74% are insured, while only 8% were able to see their PCP. And part of the reason is some of the stuff that we talked about already, not being able to leave their belongings, not having transportation. But there's also part of it is our fault, to be honest, where there's actually studies that show that there's a distrust in physicians and feeling unwelcome or discriminated against in the healthcare system based on previous negative experiences. So this is not just they don't like systems, but actually something that we've earned. And it's not just a feeling, but actually there have been significant disparities in in-hospital care and mortality between homeless and non-homeless adults with cardiovascular disease. So this is not imagined, but people are actually getting worse care. And so this is how we've built our program. This is unique to USC, unique to Los Angeles, and if you're going to build a program, yours will be unique also. So we have 4 arms to our program. We have the arm that does street medicine, the clinical care. We have 6 full-time teams that have the prescriber, nurse, community health workers, psychiatric care, and HIV specialist, workforce development and education, which trains others how to do this work, a research arm, and a policy and advocacy arm. And so I just wanted to share some of our hepatitis C outcomes. We actually have a 24% positivity rate of everybody that we test has tested positive for hepatitis C, and then an 82% treatment completion rate. So this is not just, so this is our ability, it also demonstrates our ability to follow patients over time, that this is not intermittent care, that we're able to follow them around the street as they're being moved. So part of this is, yes, it's great we can treat Hep C, but if we can treat Hep C and follow patients longitudinally for this, we can do it for any disease. And we've also shown very good data on outcomes. Following patients longitudinally over the course of a year with traditional care, about 27% were able to be seen and 73% with street medicine. Even decrease in emergency room visits down 80%, hospitalizations down almost 80%, and hospital readmissions down 75%. And so finally, just some best practices. First, as we're thinking about building a system and longitudinal care, access will always be number one. Without access, there's no longitudinal care, there's no comprehensiveness of care. We follow the moniker to go to the people and then go where they go. So we don't have a separate team that does hepatitis C. It's embedded with the rest of the team. As they get moved around town, we follow them. If they get placed in housing, we follow them there too. Back out onto the street, we follow them there too. And then again, the teams are fully integrated. Primary care, SUD, behavioral health treatment, all of it is street-based. The more referrals that we do, the more chances that something will be dropped. So we try and bring it all together. And that the care in general is very much connected to the system. The patients are in the electronic medical record. Their care looks just like anybody else's care, but is built from the street backwards, rather than starting in the system and figuring out how to fit them. And with that, I will hand it over to Dr. Bear.
Thank you very much, Brett. I was actually incredibly nervous to go after you, Brett, because Brett has a TED Talk. Brett has done this and sort of sets the bar very high. He's inspired many to start street medicine teams, myself included. So with that, I really wanted to focus my short 10 minutes on our team specifically in Bakersfield and what some of the unique challenges we have and some of the unique joys we're able to have here as well. So Bakersfield is in Central California. It's a couple hours north of Brett. This is what I think of. I asked ChatGPT, like, what does hell on earth in Bakersfield look like? And this is what ChatGPT came up with. This has nothing to do with the tragic recent LA fires. This is just how so many people envision Bakersfield. It's a really, really rough area. We're, I think, lowest in education in the nation, lowest in illiteracy, or I guess that would make us highest in illiteracy. Just crazy disease states. We have very, very rough summers where temperatures get up into 114 degrees. So it is already an unfavorable place to live. And our patients are sort of at the worst of it. We have 5 teams that service a variety of areas in Bakersfield. This particular patient, 2 patients actually, were on the river and they came out off their island on a canoe to come visit us. We also have teams that go to an area north of here, just an hour north, that is Lake Isabella. And to the left of your screen, you can't really see it here. We actually have a couple patients who live in a cave up here. It's a beautiful countryside, which is sad given the disparity of the patient living situation. Our teams are visiting under bridges. They go down by railroad tracks. So I'm really glad Brett did an amazing job sort of laying out what street medicine is. And we have tried to follow that practice of going to the people no matter wherever they are as well. So what really separates our team, or what I've seen noticed from our team from a lot of other teams, is our patients have tons of pets, tons of animals. This is a possum, a baby possum that one of my patients was keeping. And that same patient, probably a year or two later, had this rat. And then a year or two later, there's this slimy creature holding a snake that was also the exact same patient. So aside from these odd animals, we've had baby bats that one of our patients under the bridge was actually, they would fall from under the bridge, and he would feed them to his pet pit bull, which I don't think is probably good for the pit bulls. We have cats, kittens, all sorts of kittens. Sometimes we have baskets of kittens. We have lots and lots of dogs. We had a shark, believe it or not, even out here in the desert area. We have had overwhelmingly the animal we see with our patients are dogs. Lots and lots and lots of dogs. And some of these dogs are just the most beautiful animals and friendly, kindest, protective, most wonderful creatures we've ever had the pleasure of encountering. With lots of dogs comes a few things. One is you get lots of puppies. And so we've built into our team veterinary workers. So we have vets who come out with us and provide vaccinations and care to these animals because they mean a ton to the patients. If given the choice, our patients will 9 times out of 10 forego their own medical treatment and ask that we just take care of their dogs. And so we see cages of puppies. We see this is a laundry basket full of puppies. We have shopping carts full of puppies. It's just puppies and dogs galore. The other tragic thing that comes with dogs is dog-related injuries. And I do want to stress, like, these next images are pretty gruesome, and I'm not trying to sensationalize the suffering of people I love dearly. But this is a reality that my patients live with literally day in and day out. So with dogs come dog attacks. And this was one of our patients who, when we came upon her, was being literally eaten alive by 5 pit bulls. And so you can see that there are pieces of flesh missing from her arm, and that is where they had consumed this patient. So you can imagine what that does to your psyche to sort of see yourself as this vulnerable, right? The same pack of dogs tore one of my other patient's arms apart. This is post-surgery. You can see the tendons are no longer intact. This patient has had several surgeries and has no real meaningful use of the dexterity in his hand. Thankfully, the first patient, this is her post-operative scars. She's doing very well. She has pretty good use of her arms. She is deathly afraid of dogs now, as we all are. So our harm reduction looks a little bit different. We don't take a lot of pictures of what we're doing harm reduction, but we try to do the same basic stuff. We provide syringes, we provide clean injection equipment, we provide as much education as we can. We use a harm reduction approach, but it also means we need to keep in mind, like, what does it look like to protect yourself from wild animals? So we try to educate our patients on staying in groups and not going out alone, because that's where we have a lot of patients get attacked by animals. Other like normal harm reduction. Oh, this is harm reduction with a puppy. I thought I should throw that in there. We also want to make sure we're providing Hep C screening. So we provide point of care Hep C. We are chomping at the bit to get the point of care RNA test out there. We also have the same philosophy as other street medicine teams. We see it all as Hep C care, substance use treatment, diabetes, high blood pressure. It's all under one roof. We don't compartmentalize it. We will treat our patients on site for any of these illnesses. We are just breaking into ground, being able to draw blood on site so that we can start rapid initiation of treatment for hepatitis C. With that being said, I wanted to make sure I kept it under my time, and I did. I'm going to pass it on to Benjamin. Thank you guys so much.
Thank you, Matt. So just to introduce myself again, my name's Ben Eckhart. Although I think in the introduction I'm listed, and I still work at NYU School of Medicine. A lot of the work I do and will present here is part of my work with the city hospital system, the New York City Health and Hospitals. And sort of walking you through how I got into it. I didn't start in street medicine. I started in sort of hepatitis C. And I know Brian Edlin, I noticed, was on the participant list. And a lot of what I started with was low threshold hepatitis C treatment, and been doing it really since 2014. And I think Brian has been doing it at least for a decade before that point. What the model that we looked at was specifically bringing hepatitis C care intentionally to where people who inject drugs commonly congregate, and that ended up being in syringe services programs. So for many years, we worked and studied sort of hepatitis C treatment in this arena. However, if you delve into a lot of these studies, a lot of these models, increasingly I realized that we were only capturing probably about 50% of the people that we needed to capture. In addition to that, I think as Matt and Brett have both mentioned, we were oftentimes neglecting these individuals' other medical conditions. And I felt a little bit siloed in this sort of environment where we were really focusing on hepatitis C when there were so many other ongoing issues. So, this is sort of a schematic of what I like to consider what we do. And it, again, coming from the HIV world, from the infectious disease world, I stole this figure from the CDC, which has this concept of status neutral HIV care. It specifically was drawn for high risk sexual practices. And I sort of have adapted it for people who inject drugs. And I think it gives you a flavor for what we try to do, which is really everything that this patient population needs. It's obviously, we're talking about hepatitis C here, but it's really sort of low threshold, destigmatized, flexible, and co-located quality care, independent of HIV status, hepatitis C status, and importantly, integrating things like harm reduction and medication for opioid use disorder, in addition to treatment of bacterial infections. New York City Health and Hospitals is the public health system in New York City. It actually is 11 acute care hospitals. At the time of COVID, the system invested in mobile units to do COVID testing and eventual treatment. As the COVID pandemic wound down, those vans were repurposed and were kind of late in the game for a large metropolitan area and started repurposing them for street medicine. Although our van is a mobile unit, we just park and then we rove from those vans. There are currently 6 vans around the city. They're typically staffed similar to some of the other models with a prescriber, typically an MD. We have an RN, oftentimes an addiction counselor and/or a social worker, in addition to some community health workers who have lived experiences. We, on our van, also are excited to be welcoming a psychiatrist 1 session a week, which I think is something that we've been dying to have integrated as well. I specifically work on the South Bronx mobile unit, and sort of what we do, again, listed here in just a list, is really, trying to focus on not only drug users, which is a big issue in the South Bronx, but homeless individuals in general. We provide primary care. I think there's a lot of excitement around things like buprenorphine, specifically with long-acting injectables. We do a lot of HIV prevention and treatment as well, starting to integrate more and more long-acting injectables into that model. Wound care, bacterial infection management, and this is also included, again, long-acting antibiotics like dalbavancin in rare cases. You can see and read what else we do, but it's really trying to be as comprehensive as possible. In terms of our hepatitis C treatment, we get our patients from various sort of referral sites. Most of them are actually existing patients, and I'll talk a little bit about that in a second, but we also are work in close partnership with certain service programs, in addition to overdose or opioid treatment programs. We're proximally located to several shelters, a soup kitchen, a couple of safe havens. And although our neighborhood is not one of the sites in New York City that has a supervised injection site, we have 2 well sort of known outdoor injection sites that we oftentimes frequent. In terms of, capturing our patients that are already within our system. This is just some of the powers that we can do with Epic, which is any patient that has ever been seen by our van, if they're registered, integrated into our system, we run them through sort of Epic's splicer dicer, and we can get a sense of if these patients have ever had a hepatitis C antibody test anywhere in this public hospital system, and run a report to see if they've been treated, cured, or basically need additional testing like an RNA. So, this is just a 6 months screenshot of 130 patients that have hepatitis C antibody positivity, and give you a sense that we still have a fair number that we're needing to track down to cure, but there are a fair amount that have either been cured or cleared their infection. In terms of our map, we are located sort of in the Mott Haven Melrose section of the South Bronx. Our van sort of parks in the general area of that target, and to the left is actually Lincoln Hospital. We do have a hospital-based clinic that is geared towards individuals with that are experiencing homelessness or unstable housing in addition. So those that need a more sort of hospital-based environment, we oftentimes can partner with them. It also allows us to get over some of the barriers related to storage of things like Brixadi or Sublocade, that we can literally walk these couple of blocks to figure out a solution to get these medications or other supplies that we might need. So our van is located there. Within this greater picture, there are actually one brick and mortar syringe service program. There are 3 mobile syringe service programs that also are in this area. There are 3 methadone clinics. And as I mentioned, we have soup kitchens, safe havens, outdoor injection sites throughout this area as well, within a short walk. So again, we park our van in the beginning of the day and we do not move it. We do most of our work on foot. From the logistic standpoint, in terms of hepatitis C testing, we ended up deciding to focus on a phlebotomy-based model while also utilizing historic labs. We had some discussions with Cepheid, but we decided not to pursue our point-of-care RNA testing. Part of that was because the RNA testing had been used a lot in sort of these rapid treatment models, get the test result, get them on treatment right away. And we felt that there was a real key component to building a relationship with our patients in a longitudinal capacity to deal with all of the other multitude of health issues that they're experiencing, in addition to the social issues. Additionally, we have a small van. It's not a big van. You'll see bigger vans. We decided against the Cepheid machine because we wanted to have other machines such as point of care ultrasound, and just didn't have the physical space to provide that. In terms of medication procurement, we work very closely with a specialty pharmacy in the area. New York State Medicaid, I think in California is probably similar. It's pretty common for our patients to be insured with Medicaid, and there is no longer any prior authorization for Medicaid individuals who are treatment naive. We have a specialty pharmacy that I've been working with for a long time that's been great, and they deliver the medications to our van. And then the medication distribution is sort of personalized. Some patients need to come back weekly to get their medications. Some patients need to take it all at the same time if they're housed. One of the challenges that we continually run into, I think there are many. Obviously, a lot of these individuals are in and out of carceral settings. The other thing that we oftentimes run into is that the New York City shelter system does not sort of take into consideration neighborhoods. So there's a single men's intake shelter in Manhattan, and then you get placed anywhere within the city, which could be 2 hours away from where our van is placed, for instance. So patients, as we're trying to find them housing, there's a significant chance that they may end up leaving our immediate neighborhood. And oftentimes we partner with some of the other vans to try and facilitate that, versus coming up with all sorts of other solutions. Just to give you a real quick example, I just sort of pulled the most recent patient that we started on hepatitis C treatment this last week. Give you an idea of what we're dealing with, but she's a 37-year-old woman experiencing street homelessness. I first engaged with her in January and specifically had was complaining of a hand on her left, a wound on her left hand at the site of a prior injection. Again, it wasn't like a severe infection, but it certainly needed antibiotics and cleaning. And I think some of the other sites mentioned that they do similar activities. She also had a neck ulcer at one of her injection sites and was complaining of vaginal discharge. She reported engagement in transactional sex. So in terms of the left hand, cleaned and dressed, prescribed oral antibiotics. For the neck wound, we did do a point of care ultrasound at the van just to make sure that there was no residual abscess as she was complaining some drainage at that point. In terms of her vaginal discharge, we treated her empirically based on her high risk. We did additional HIV and STD testing and started the discussion about PrEP. A lot of our individuals that we engage are not super excited about PrEP at this point, but I think that might change if we can get FDA approval of lenacapavir, which is every 6 months for HIV prevention. So started that discussion. And then sort of looping back, realizing that she was still hepatitis C infected and treatment naive. The second visit with her, we obtained the remainder of her baseline labs. 1 week later, her bacterial infection and vaginal discharge had resolved, and we've subsequently started her on treatment. I'll flip it back to Liv to open the floor.
Thank you so much, Brett, Ben, and Matt, for your fantastic presentations. And thank you so much for taking the time to share your models with us. We've got a bit of time now for questions. So I've just stopped screen sharing so we can really have a conversation about some of the different things that have come up. What I might do is work through some of the questions in the chat and then really open the floor for you all to take yourselves off mute, either present your questions to the presenters in the chat or take yourselves off mute and ask them verbally. But I'll start with the questions in the chat because there's a couple of ones in here which I want to address. So firstly, I think this one might be for Brett. It was posed relatively early on in the piece, and it's around the process to be able to use the POS 27. The question is, does it take a long process of approval, or is it easily available to providers like other codes are?
Yes, so this would be US specific. So basically the reason why we needed the code, and then I'll get into how to actually use it, is because when you bill for what you do and where you do it, and there was no where of the street. So so that's why we needed the code. So the federal government approved it, but then each state had to implement it. They'd have to, add it to their IT system so that it could be used. And then the individual providers have to add it to their electronic medical record so that their billing departments can use it. And one of the things we tried to do to speed that up is reach out to states to ask them to implement it already. Most have done it. And then reach out to the large EMRs like Epic and stuff that like Ben was talking about, so that Epic would just put it in so not each individual provider would have to do it. Assuming it's already in there and activated, you would use it just like any other code. So when you bill for, a diabetes visit or something, you can just, you'd have to work out with your own IT department how to indicate that visit was done on the street based on the place of service code. But every visit already has a code.
Fantastic. Thanks so much, Brett. There's also been placed a great video in the chat. I encourage you all to check it out, a YouTube video. There's also some great opportunities for collaboration I'm seeing in the chat, which is fantastic. This question, I believe, is for Ben. It's around the Hep C registry. So it'd be possible to get a little bit more specific information around how to develop and implement Hep C registry.
Yeah, I mean, so it's basically speaking, I can really only speak from Epic, but Epic has some capability to basically look at charts and pull out a specific data. A lot of the back work, I will say, was done by the IT team to create an HIV registry for all of health and hospitals and a hepatitis C registry for all of health and hospitals. What we did then is we took that registry that already existed and we basically attached it specifically to patients who have had encounters with our van. So when we write a note, when we document a visit, it's an encounter. So basically what we're asking Epic is anyone who's ever had an encounter with our street medicine team, are they in the hepatitis C registry? And we do the same thing with the HIV registry. And then we have certain columns that for HIV, it's, have they seen a provider? Is their HIV viral load undetectable? And for hepatitis C, it gives some of those additional details in terms of cure. I was not involved in the registry. I can certainly connect you with our IT team here at Health and Hospitals to help develop that registry. That was a bit of a process to develop, but sort of we've just tacked on our, for lack of a better term, clinic and looking at our clinic data. But then what we do, as opposed to a lot of the other clinics, which those are their patients, we see those patients and we may never have had a discussion about them, about hepatitis C, but now we know, okay, there's this, 12 patients we know that we know where to find for the most part, and we should go and sort of tackle them when the time is right, or maybe just the next time we encounter them, bring up the topic of hepatitis C treatment and see what they're.
Fantastic. And just a very quick follow-up question, Ben, before we move on. I see there's some hands up in the audience, and this might be one also to pass on, but are you using a DX as a data pull metric for the registry?
Yeah, so to be in the, by DX, you mean diagnosis?
I'm assuming.
Yeah, so to be in the registry, you need to have a hepatitis C antibody test that's positive. And then it looks at, do you have there's various points that they look at, which is, do you have an RNA? Have you been prescribed medication? One thing that it lacks at this point, and we're trying to get it integrated in, is understanding when the last RNA test is, because I think in terms of capturing reinfection, we're still potentially missing that within the registry, or at least sort of integrating the idea of this person should be retested looking for reinfection.
Fantastic. Thanks so much, Ben. I want to pass now to Jules. Jules, please feel free to take yourself off mute to pose your question.
Hi, Ben. This is Jules Levin. There's a question for you I have. So you can hear me, right?
Yes, we can.
So I listened to your talk about, your program and your vans. Are they just in the Bronx? The first question, are they just in the Bronx or all over the city? That's the first question. The other boroughs too, Staten Island, Brooklyn, so forth. And the second question is, I follow the data kind of closely, and the reason we haven't been able to, one of the main reasons we haven't been able to eliminate Hep C is because there's a lot of older IV drug users who've never been captured. They seem to avoid screening and treatment. And I'm wondering what kind of, if you could, do you have a sense of how many people you see or don't see because they avoid you in your program that you can't treat? And maybe you could comment on why it's still so difficult to capture and treat all the older people, older drug users. Thank you.
So the first part of your question, just
You
quickly,
made it.
there are 6 vans. We're in the South Bronx. There's one in Washington Heights. There's one in Central Harlem, one in the Lower East Side, one in Bushwick, and one in Elmhurst.
So he's gonna be back until it's time for y'all to go to bed.
The teams are a little bit different. Our team is probably more trained in HIV treatment, so we focus a little bit on more on that than some of the other vans. But that's the answer to your first question. It's absolutely right. I mean, I think it's neighborhood specific. There are a lot of older people who inject drugs who are not getting treating. I also think those that are really involved in the scene are just, I mean, for lack of a better word, a little bit nihilistic. And we're trying to sort of slowly build that relationship with them and try and get over that initial hump of, this is something that we can manage. But it's sort of, trying to get it to be their priority, and building that relationship. I still think we have a lot of work to do. Our program is in its relative infancy compared to what other cities like LA and Boston have been doing for much longer times. So those relationships are still a bit in their infancy.
Thanks, Ben.
Just
Sarah.
Sorry, Liv.
Oh, yeah.
So I just wanted to add to the last part. Just sharing our experience with the older people who had used drugs or use drugs now. Actually, my experience hasn't been that they have been avoidant of us, but that we haven't created the right system for them to access. So I shared some of the ED data, that we had decreased ED visits by 80%. And it sounds like a lot. It sounds like we did a great job, but we really didn't. It was actually very logical. That if you imagine that there's no PCP and the only point of entry for the entire system is through the ED visits would skyrocket. So all we did was create an alternative access point for the system that's accessible and acceptable to them, and they're very willing to go. So I think that's where street medicine plays a role in that population.
Fantastic. Thanks so much, Brett, for adding. I'll pass now to Sarah.
Hi, yeah. Thanks y'all for being here. Love learning about the models that y'all have. Work for a needle exchange that is just getting into street medicine, and we're definitely at a very like different point of like not having, we don't have like vans or RVs, we don't have like, a whole team of prescribers, we don't have insurance, all the things, right? So like, do you all have kind of any advice or recommendations for like models that like when you don't have kind of like what is like the kind of the earliest entry model like a of when you don't yet have like the RVs and like huge teams and stuff if you're just working on like one doctor friend and a your own car kind of thing.
Can I jump in real quick? I want to answer that because I started doing street medicine back in 2019, so it still feels very young to me. And I was sort of where you were, where it's like, hey, I don't know what the hell I'm doing. I just have a vision. I went out with Brett one day and I said I want to do like that, but I didn't have a ton of guidance or resources. And I'll tell you the thing that I would recommend to avoid is just don't plan it to death, because that's almost what I did, where it's like I try to come up with the best model. I try to come up with getting all the regulations and making sure everyone above me was very happy and pleased and compliant. And it went months until I said, forget it. Like, let's go right now. Let's take whatever we have with us, supplies, person with us. And we just went and started introducing ourselves to the camps. I honestly think what makes the team successful isn't the amount of resources. Those are wonderful. It's really amazing to be able to do a point of care ultrasound or point of care testing. But I think what's going to make any one team impactful is the relationships you build. And you can build those relationships right now. All you have to do is come from a place of love and do what you say you're going to do. If you tell a patient, hey, I'm going to get you those socks, I'll see you next week or later this week, do that, and do that 100% of the time, and you will make so much movement in this space. I think Brett and Ben probably have better answers, but I remember that being very real.
Thanks, Matt. Brett and Ben, anything to add?
I don't have a specific better answer. Just to say, and this is for you, Sarah, but also everybody else, is that the street medicine is a global community, but it's also a very small community, and a loving one. We're all friends. We all know each other. We share our cell phone numbers and have helped each other get started. And there's lots of other types of trainings, that you can join after this. Like, for example, National Healthcare for the Homeless, their conference coming up in May has a pre-conference institute, whole day of street medicine that we're talking about the actual logistics of how to deploy a team, what to do if there's only one or two of you, or this whole stuff. So feel free to join any of those. Everybody is very welcoming.
Anything from you, Ben, to add before I move to the next question?
Yeah, I mean, nothing groundbreaking. I agree with Matt's point about don't overplan it, and I think so much of it is local. I can tell you what the multitude of options are in New York State, but there's a good chance you're not in New York State. I mean, there's places where you can do dry blood spot, which might be an option. The good thing is, pre-treatment lab testing for hepatitis C is fewer and fewer tests. And so hopefully it's getting easier and easier, but there is still some barriers that need to be overcome.
Fantastic. Thanks for that fantastic question, Sarah. There's a question in the chat around the management of medications. The question is, how do you manage medication storage, retention from sheltered, unhoused who cannot store meds? Do you offer DOT directly observed therapy if needed? Don't know who wants to take that one. Volunteer, please.
So
I mean, just
go ahead. I'm sorry, Ben. I was gonna say, so it really is gonna be case dependent. Like Ben had mentioned earlier, when it comes to like providing the treatment for Hep C, some of that treatment is 8 to 12 weeks, and I might have one patient for whom I can deliver medication once a week, and they're gonna do really well, and I might have other patients who we literally need to find every day to deliver their dosing. It sort of depends on level of stability, level of engagement. And then in terms of other long-term meds like blood pressure meds and diabetes medications, you have to take into account a million different things, like where these patients are going to store these. Do they need to be refrigerated? What are side effects? We often forget about the medications that we need to take with food. And Brett had mentioned that some 30% of our patients eat 3 meals or less a week. So there's a lot of different things you need to consider when prescribing. It's a different ethos than when you're in a clinic, and you're going to have to individualize it. Would be my experience.
Fantastic. Thanks so much, Matt. So we've probably got time for about one or two more questions. I can't see anything coming up in the chat specifically. Does anyone want to feel free to raise your hand and take yourself off mute to ask one of our presenters a question? One more from Jules.
Yes, hi. Again, a question for Ben. I think you mentioned it. I'm not sure if I heard it, but do you provide for the right select patients? You give them their whole 12 weeks or 8 weeks to take home with them medication, Hep C?
I mean, for our street medicine patients, we have not. So New
Yeah.
York State now allows you to write the entire treatment course in one prescription. So it's not 4 weeks with refills the way it used to be. So my clinic patients, I have written that. Theoretically, I might do that for the right street medicine patient as well. I can't say that I actually have. In fact, we usually go the opposite direction, even on things like Suboxone. It's sometimes easier to write a week prescription with a bunch of refills rather than a month prescription, just knowing that a lot of these medications get misplaced. Um, so sort of looping back to the prior question, storage is an issue. I think the best thing the thing we would like is what Miami has. Miami actually has like these little locked mailboxes that are adjacent to their van, where patients can get a key and they can store their own medications in it. We would love that. We don't have that. I think there's a lot of sort of novel ideas out there. It is certainly one of the challenges that we have to deal with. But yes, I hope that answers your question.
Thanks, Ben. And I'll pass now to Courtney.
So my question is, do y'all offer any like incentives? So, I'm a hepatitis C coordinator in Virginia Harm Reduction Coalition, and we have like gift card system to like if they get their labs done, they get a gift card. If they do the telehealth, it's a gift card. So I was wondering if y'all did anything like that because that seems very successful. We also have lockers, like y'all were just talking about, store where people store their meds and stuff.
We don't use anything like that. I have heard it being successful. I haven't found that we've needed it. And I think part of it is because I've noticed, and some of you may have different experiences, which are equally as valid. I've noticed for programs, and I'm not saying this is yours, Courtney, but for programs that only test, they tend to rely more on incentives for people to get testing. When you embed the hepatitis C with everything else, they have already come to you with their knee that's bugging them, and then you started helping them with their seizure disorder. And then, it's just part of the whole relationship that you've built. And, we talk about typically care is like, we drive the care, which of course is the wrong thing. So then there's like, then you try and let the patient drive the care, which is better. But the best care is when everybody is in solidarity with each other. And you don't know who's really driving the care, um, whose agenda you're following. Like for hypertension, if they have hypertension and they want it treated, that's awesome. I'm also glad that they're having it treated. Whose agenda are we following? I don't know. We're doing it together. So I found that to work better than the incentives.
That actually makes a lot of sense because it is very much to get people coming with, and my goal is to hopefully, I'm in the process of getting my nursing license back to maybe build out a street medicine team. So it was really inspiring.
Thanks,
Fantastic. Thanks so much,
Yeah,
Brian. Anything to add, Ben and Matt?
I would just say that we also don't have incentives, but I think my experience with several different treatment models is, they start slow, but the thing that gets them going is when you create a relationship, that experience gets passed off to other people in the community. And then it's sort of this snowball effect where you're just starting to see more and more patients because they've heard that this is a welcoming environment and that they're going to have their needs met and not be judged because of some past history.
Start slow. I think that's just such a perfect way to close off this Q&A session. I'd like to say just a huge thank you to our three phenomenal presenters for coming to take their time to share a little bit about their models of street medicine today. I'd also like to thank all of you in the audience for your engagement, both in the chat and in this discussion. It's so great to have your questions coming through, and we hope to be able to continue this conversation and continue to form some collaborations. I see there's already some networking going on in the chat, which is fantastic. I just want to take a very quick second before we wrap to encourage you to get involved across the broader INSU network. This is just one event of many that we run across a variety of different programs, and would love to have you involved as a member. There's some information up there. Members receive a variety of different benefits, most notably a discount to the annual conference, which I mentioned at the start of this webinar. It's going to be held in Cape Town in October, and it's a really amazing forum for all of us to come together and continue some of these discussions. So really encourage you to come along and check it out. There's different sort of discounted levels available depending on affiliation and that type of thing. And there's more information available on the website about INSU membership. And then finally, I'll send this around after the webinar along with the recording of this webinar. So no obligation to fill it out now, but we'd really love to hear from all of you. I think there's about 100 people here today. We'd love to hear about your models of care. We always are looking for different innovative models of care to showcase, whether it's in our education and training programs or in some of our knowledge exchange activities. So we would really love to hear from you about some of the work that you're doing across the states in hepatitis C elimination and different challenges that you're experiencing, so that we can continue to strengthen this amazing community of practice that we're building. So yeah, again, thank you for attending. My email's up there on the screen if you have any questions. I'll be in touch after to share the recording from the event. I know there's been a few requests for it in the chat. And have a lovely rest of your afternoon, everybody. Thank you again to our presenters for coming.